Greetings, everyone. Welcome, and thank you for joining the 20th webinar in our Pandemics and Societies series. Today's webinar topic is the cost of defunding PEPFAR and the impact on the fight against HIV and AIDS. Today, we will be discussing the President's Emergency Plan for AIDS Relief, or PEPFAR program, its importance since the establishment in 2003, and the potential consequences of the program not being reauthorized. I'll now pass it to our moderator, Wilmot James, Senior Advisor to the Pandemic Center and Professor of the Practice of Health Services, Policy, and Practice at the Brown University School of Public Health, to begin today's conversation. Wilmot?
Thank you, Leah. So good morning, good afternoon, good evening, everybody, and welcome to our webinar. I wish we didn't have to have this webinar, given the crisis we are about to discuss, but we do have this webinar today, and it's a good forum for us to navigate our way through how we deal with this particular crisis. So to note that according to history, PEPFAR was established in 2003, and the United States has invested over $110 billion in its global response to the HIV/AIDS pandemic. And in particular, it has been a critical player in supporting the response in Southern Africa. PEPFAR is the largest commitment in history by any country to address a single disease. It has been instrumental in providing countries with life-prolonging HIV-suppressing therapies and its supporting prevention programs. According to the US State Department, it has saved, the PEPFAR program, 26 million lives and prevented millions of acquiring HIV in more than 50 countries. However, as you've have seen, the recent shifts in US policy, as mandated by the executive orders from the second Trump administration, threaten to disrupt many life-saving humanitarian aid programs such as PEPFAR, negating decades of progress, and it jeopardizes the health and lives of millions of African citizens and more. We learned overnight that PEPFAR has been terminated in its entirety and with immediate effect. Projects affected range from mother-to-child transmission programs and hospices to research, as well as to research groups. Let me just say that beyond the immediate human toll, the economic losses and the risk for spreading of the virus to neighboring countries and the regions would be substantial. While the US federal government can deploy taxpayers' funds as it wishes, it's the right of the US government to do that. The wholesale and immediate withdrawal of PEPFAR funds is a reckless act of great cruelty, affecting many lives of adults as well as children. To help us learn more and reflect on this topic, we are fortunate to be joined by two experts from the US and South Africa. And to start with, by way of an introduction, to Dr. Glenda Gray, who is the Director of Infectious Disease and Oncology Research Institute, otherwise known as IDORI, at the University of Witwatersrand in Johannesburg, and the former President and Chief Executive Officer of the South African Medical Research Council. Also joining us today is Stephanie Saki, a distinguished senior fellow in global health security at Brown University School of Public Health, and the former US coordinator for global health security at the White House. So thank you both, Glenda and Stephanie, for joining us today. We will start with a few initial questions, and we would like to ask our viewers to please feel free to utilize the Q&A function so we can answer your questions later in the discussion. So if I then can start by asking the following question of our panelists to tell us what is happening with PEPFAR at present. What do we know and what do we not know? And if I can turn first to Stephanie and then to follow that by turning to Glenda. So over to you, Stephanie.
Sure. Thank you, Wilmot, and thanks for bringing us together for this important and unfortunately very timely conversation about the risks to PEPFAR and the people who have participated in and benefited from PEPFAR. I just want to start by acknowledging that the last few days and weeks have been incredibly difficult and disappointing and horrifying in a lot of ways. As someone who was part of the Biden-Harris administration, but worked alongside the many wonderful staff in the US government, many of whom are still there or being fired right now, did not imagine that this is how it would unfold over the last few weeks. I'm very surprised, and I know that this is not what many, if not most, Americans want to happen right now. So I just want to express that we share the pain and disappointment and frustration about what's happening right now, and also are trying to roll up our sleeves and figure out what to do to kind of stem the emergency situation and also think about what comes next. So I wanted to start with just acknowledging that the incredible challenge of this moment. So I think you did a great job framing kind of where we are now. I will lay out my understanding of what has unfolded over the last few weeks, and I just want to recognize that KFF has been doing some really great work summarizing the steps every step of the way, because it's really hard to follow. But as everyone here probably knows, very early in the Trump administration, there was an announcement of a 90-day pause in foreign aid funding, with the purpose of reviewing the funding, mostly to make decisions about future funding or future appropriations, which to some extent is something that every incoming administration does, not in such a stark way, but you reevaluate the extent to which your investments align with the policies of the new leadership. So I think that piece was not particularly surprising, and if undertaken in a more systematic way, I think would have been maybe frustrating, disappointing, but not had the impact that we're seeing right now. Shortly after that, however, on January 24th, Secretary Rubio, the Secretary of State, issued a stop work order on foreign aid programs. Some programs received waivers, some life-saving programs received waivers under that stop work order, and PEPFAR received a limited waiver on February 1st, at least in principle. However, the reports, and Glenda might have more to share on this, and I'm sure those who are listening do, the reports were that there was a multi-step process to actually get that waiver implemented, including having staff in place at USAID who can help keep the trains running, who are not there to help it keep moving. So even with the limited waiver, my understanding is that most programs were not able to continue. Even with that waiver in place, it only applied to care and treatment, as well as prevention of mother-to-child transmission and PrEP for pregnant and breastfeeding women. But that meant that things like HIV prevention services for key populations and adolescent girls and young women were not included in that waiver. So I think that is a informative signal about where the policy priorities would be in some version of PEPFAR that were to continue if that happens. And of course, I mentioned this, but most at this point of the USAID staff have been fired or placed on administrative leave at this point, which obviously makes it very difficult to administer funding, even with waivers in place. Then in the last few days, kind of in the context of a number of legal cases, the Trump administration announced that it had completed a review of programs and essentially canceled most of the existing foreign aid contracts, including most PEPFAR contracts, some of which had previously received waivers. So I think that has created a lot of confusion about whether the waivers that the State Department provided, are the ones that are still in place, whether the cancellation is, going to hold, et cetera. But just to give, I think there are a lot of examples of PEPFAR programs that were terminated. Just one, because the Elizabeth Glaser Pediatric AIDS Foundation released a public statement about one of their, I think a couple of their programs that provided HIV treatment to more than 350,000 people, including 10,000 children and 10,000 pregnant women. So I think that's just one or a couple of many And then we just learned that the US government is going to stop funding UNAIDS in the last couple of days. So that is, I think, the current status. I will say, although, as I mentioned, I continue to be shocked and disappointed by how things are unfolding. Having worked in the White House on PEPFAR, including on reauthorization, I do feel that there's more support for PEPFAR in the US Congress than for a lot of maybe any other foreign aid program. So I don't think we're at the end of the story yet on PEPFAR, but we are in a very dire situation. And I think anything that we manage to salvage as a community will probably be a shadow of what PEPFAR was previously. That's my best assessment in the midst of a lot of uncertainty.
But many thanks for that overview, Stephanie. If I can turn to Glenda to talk to us about what her experience has been in the impact of this in Southern Africa, both the clinical side and the public health side, and to specifically talk about the impact on the program preventing mother-to-child transmission. Over to you, Glenda.
Sure. So, Wilmot, you reminded me that in 2003, I was one of the first beneficiaries of the PEPFAR program at the Perinatal HIV Research Unit in Soweto. And this PEPFAR program in those early days allowed us to give pregnant women antiretroviral therapy and start to roll out PMTCT programs in Soweto. At the same time, we were also able to put adults on treatment, and over a 6-month period, we were initiating 100 adults a day on treatment. And so I witnessed over a period of a year sick kids coming into our clinic, lying on the floor or on the benches, and the next couple of months, them being able to play and color in, go back to school. I saw eventually the eradication of wheelchairs, oxygen, and drips in our clinic, and a clinic that became vibrant and people full of life. So literally, the PEPFAR program breathed life into the patients that we served in Soweto, and I saw this Lazarus experience of people getting back and being able to be economically active. And over the years, PEPFAR did change the life expectancy in South Africa from a low when people were dying in their droves at 23, 24 years of age, and breathe life expectancy of over 6 years over this period. So certainly for us in South Africa, the PEPFAR program came at a time when there was AIDS denialism, and this program allowed us to put people onto treatment. And over the years, the South African government managed to take over a lot of the initiatives and become more or less the major funder of the program, and at a position where now pediatric HIV or HIV in South Africa in children is controllable to a large extent. So what does this program, the cessation of this program matter in South Africa? So although the South African government procures the treatment, the ARVs for the population, it relies on other partners like PEPFAR, which accounts for about 17% of the total budget, to deliver quality care, to ensure that testing occurs, people are initiated onto treatment, and that particularly in the pediatric sections and in pregnant women, that women can be diagnosed and initiated on treatment. And so we have about 7.8 million people on treatment at the moment. And for our PMTCT program, we estimate that about 230 children may lose access. 230 children who are born to women living with HIV may lose access to treatment, and that a third of these may die before they reach 1 year of age. So for South Africa, the immediate target and the most vulnerable people that will be affected by the PEPFAR program loss will be infants and their mothers. And so we will see a reversal of the gains that we've made, and making again pediatric HIV, another terrible scourge for child health. And so those are the kind of issues that we face. So I'm also at this moment in time, although I was a beneficiary of a PEPFAR program in 2003, about a year ago I got a cooperative agreement from USAID, and this is for research and development. So myself and alongside a lot of colleagues who are involved in implementation science received these pause stop work orders, from the 24th to the 27th of January, which led to a huge anxiety amongst the people, healthcare workers in South Africa. So we've tens of thousands of healthcare workers have lost their jobs. Which means that people who were the beneficiaries of this care will no longer be that. And those are the areas of the country where they most need this intervention. So the PEPFAR program, although only 17%, focused on the hardest hit districts in South Africa, and again and amongst key populations. So if you take your foot off this accelerator, you basically ignite the fire of HIV transmission again in our country, and we will see reversals of the gains that we've made, and a loss of getting people onto treatment, and an increase in HIV transmission, which will be insidious. And I guess in some ways we'll only begin to see this unravel over the next couple of years, except in the children, where it'll be more acute and more visible. So I think we're going to be seeing an insidious increase in mortality amongst young men and women and their children in South Africa over the next 5 years.
Thank you very much, Glenda. I just wanted to say that between 2009 and 2017, I was a member of parliament in South Africa, and I was the ranking member from the opposition on the health committee, while Glenda was the director of the Medical Research Council, and leading pediatrician in the country. And just to acknowledge Glenda's extraordinary leadership during that period in rolling out her contribution to the management of the HIV/AIDS pandemic. I also wanted to say that there was agreement between the opposition party that I served at the time and the African National Congress in that committee about our moral responsibility to, in fact, sign off on a budget that is really big on an annual basis to support HIV/AIDS rollout in the country. So, so let me just follow up the discussion now to ask, what are we to do immediately and in the short, medium, and long term? And we don't represent, and you don't represent, the South African government, but what do you think, and I'll start with Glenda, what actions ought to be taken in your view by the South African government and the current partners other than the US when it comes to financing the gaps and having a sustainable program?
That's a great question. And I think the issue around the current HIV program is around the quality of care that needs to be continued. And this quality of care means being able to diagnose people with HIV, to continue the HIV testing and counseling program, as well as the rapid triage into care, and to make sure that drugs are procured and are sent to the clinic. So we need input on all areas of the value chain, from diagnosis to retention in care, as well as being able to finance and make sure that drugs are ordered, they get to the warehouse, and then there is a supply chain management system in place. So I do fear that there's a lot of the quality of the ARV program in South Africa is under jeopardy because some of these things were taken for granted. So in terms of what we need, is we definitely need that 17% of the budget that PEPFAR gave, and to ensure that we get to the places in South Africa which are the hardest hit, and also the places where we managed key populations to make sure that we can treat and diagnose and treat people. Wilmot, at the moment, we see a lot of we're seeing a lot of immunocompromised people in hospitals. We're seeing a resurgence of TB. We're seeing cryptococcal meningitis. We're seeing low CD4 counts, and so we do see a lot of symptomatic people, which we haven't seen for many years, which means that our systems in South Africa are worsening since COVID. And so although the USAID PEPFAR program represented 17% of the budget, I think we need a lot more money to manage the whole system of care and prevention and care. So I haven't even spoken about prevention yet. We need to ensure that we don't stop giving PrEP to young women and key populations, and we need to make sure that we continue with all the prevention and support that was happening. So I fear also that although our treatment programs will fail, our prevention programs are even more at risk of failure, and our ability to curb infections in young women.
I should know how to do this by now. Apologies. So Stephanie, thank you, Glenda. Stephanie, would you mind commenting on the financing aspects?
Sure. So I think it's very helpful to start by hearing about the specific challenges in South Africa, which is maybe better positioned than almost any other country that has been receiving PEPFAR funding to respond effectively in this moment. I was looking at a resource that UNAIDS has shared on their website that shows the proportion of funding for treatment, for HIV treatment in different countries that comes from the US government. And just to give a few examples, so in DRC, nearly 90% of the funding for HIV treatment comes from the US government. In Haiti, more than 60% comes from the US government, but 100% of it is donor funded. In Ukraine, 30% comes from the US government, 75% is donor funded. So, thinking about, I think to Glenda's point of what are these acute gaps and the highest priority, where you are going to start seeing morbidity and mortality quickly and incidence increase quickly, what are those most urgent gaps that need to be filled by other sources of funding? So there, of course, in theory, are other donors, although the UK obviously has announced a cut to their foreign aid budget as well. And Global Fund, a big portion of their budget has historically come from the US government. Of course, there are many other donors, but I think expecting and relying on the same set of donors to fill these gaps, I think is probably unlikely to happen. The question is, who else can be brought into the fold? What is the role of the private sector in an emergency moment like this? What is the role of multilateral development banks? What is the role of some of these innovative financing approaches that we've been talking about in the health space for a while and haven't, I think we've made some progress, but now is the moment to put those in place. So I think there's kind of emergency filling the gaps. How do we quickly surge funding to fill those gaps? And in the meantime, how do we start to build a system that can replace the role that PEPFAR has played, even if PEPFAR continues in some form, which I remain hopeful that it will continue in some form. I think the stark reality is that whether a child survives in South Africa should not depend on who's in the White House in Washington, D.C. So the system needs to be different going forward on a whole range of issues.
Thanks, Stephanie. Could we focus on what would be the critical first, what would be priorities in terms of financing? I mean, we were talking about the pediatric side of this. And if we have to set priorities for immediate action in terms of children, what would that be? And how could that be financed in particular? Do you have any thoughts on that, Glenda?
Yeah, so I think the most important thing is to make sure that women get access to HIV testing as soon as they're pregnant, and that the mainstay of the PMTCT program in South Africa is early diagnosis and rapid initiation onto care, onto treatment. So we do need to focus on HIV testing and rapid triage into care, and then ongoing HIV testing during pregnancy and in the breastfeeding period. So we know that that the most common causes for babies to get HIV is the lack of diagnosis during antenatal care and lack of initiation treatment, and also the lack of diagnosis in women who deliver and seroconvert during the breastfeeding period, which is a critical period where a lot of transmission occurs. We also know that the biggest burden of pediatric HIV in South Africa is from undiagnosed women. And so the way we can approach this is to ensure that we target HIV testing in antenatal care and make it one of our first priorities. And HIV testing is not expensive. It's a rapid diagnostics. You need a nurse, you need your rapids, and you need to be able to initiate treatment very early. And so this is, should be one of the key avenues that we should target in South Africa. There are a million babies born each year, and that target, so we need to target the million women who are falling pregnant, and making sure that they get diagnosed as rapid as possible. We know up to a third of these pregnant women will be living with HIV, and so we need to have a strong drive to ensure that no woman in our country has a pregnancy that is not related to being HIV tested. So that would be my first area of concern. My second area is just to ensure that ARVs are available at antenatal care, and that there's a rapid initiation of treatment. I've seen in other parts of Africa is that there's sometimes delays. Women are referred to other settings, and there can be weeks before they get their treatment. And so the having rapid access to ARVs at the point of diagnosis is going to be critical for pediatric HIV infection.
Thanks, Glenda. Could you just confirm that ARVs are essentially produced by Aspen Pharmacare, I think, and it may be others as well? Can you just describe who the manufacturers and suppliers are?
Sure. So the government has a national tender, and various generic suppliers in the country and elsewhere submit their dossiers for the tender process. And at this moment in time, there are Aspen and some pharmaceuticals in India supply the ARVs to South Africa. So South Africa pays for these antiretroviral therapy through a treasury bond to the NDOH, and these ARVs are available and are purchased by the government. And I think the trick now, what we have to make sure happens, is that they don't get stuck in warehouses, and we do adequate forecasting and adequate movement of drugs to the places where they're needed, particularly rural areas and districts where we know are hard hit by HIV.
So Stephanie earlier mentioned the fact that there's a bigger role to be played by companies in this area, and clearly this is a matter of logistics, because it's very good, obviously, that the South African government, in its relationship with both the South African-based company Aspen Pharmacare and Indian suppliers, have that system in place. It's financed, and therefore that is not an issue, or certainly not a primary issue. And then the question is getting it from the warehouse essentially to patients, and that logistical operation can be supported massively by companies. Would you care to comment on that, Stephanie?
Yeah, I mean, I think that this is, as we try to look for solutions or at least actions, I think this space is a really important one to focus on for a minute, which is that the role of PEPFAR in bulk procurement of ARVs is really critical, and Global Fund obviously is doing a lot of that work too, and can continue to do that work. So I think one piece, and South Africa has its own agreements, but again, many countries don't. And what we don't want is to see in this moment of restricted resources, every country trying to negotiate and figure out their own rates. So I think bulk regional procurement for the Africa region will be really essential. And one question is whether, not to put Global Fund on the spot, but whether Global Fund can work out with national governments that they are doing bulk procurement as they have already done, and then the governments are buying in somehow to get lower cost ARV. So I think whatever, or does Africa CDC have a role to play? Whoever is playing the role, but I think the bulk procurement piece is very, very important also in terms of driving down prices and to guarantee purchase to these manufacturers who now have a lot of uncertainty about who is going to buy the products that they've been manufacturing. So we can also see, we have a lack of resources, but we could see the price increase if there's not large enough procurement happening. So I think that's an important question that I imagine Global Fund is thinking about already. I think, the logistics question is a really challenging one because, again, in many countries, this is the role that USAID and USAID partners have played. But I think that part of the argument, again, still holding out a flame of hope here that we can pivot in the United States. I do think one of the arguments to make, if there is an interest in, for example, maintaining HIV treatment, is that you need a series of treatment. You need, yes, the funding to procure ARVs, but you also need the logistics support and the distribution support. And how will that happen? So I think, coming back to the sort of Washington context of the conversation that needs to happen with members of Congress and even, with some of the political leadership in the US government right now, is just really walking through some of these steps that I think are not necessarily obvious to people who are in the midst of this chaos right now.
So thank you very much. So there's a comment from a member of the audience saying that this is an opportunity for the transformation of ARV delivery in Southern Africa. And the fact is that what we should do with this crisis is in fact begin to think hard about doing things differently that is more sustainable. And one of them has to do with logistics, distribution, innovations. And I just want to say that we agree with that. Thank you for that comment. And on that note, what do you think the role of UNICEF is in this? We need to understand how the financing of UNICEF as a UN agency works and how vulnerable it is. But UNICEF has been the monopsony, that is, it's a monopoly in terms of distribution of vaccines to children globally. So it clearly is an important player. So how would you see the role of UNICEF? Let me ask Stephanie that question first, and I'll ask Glenda to comment.
Yeah, I mean, I think I also concerned about the funding for UNICEF and what that will look like. But assuming that there are areas that can be carved out, like routine childhood vaccination, I mean, perhaps, so UNICEF in theory can play a critical role and ideally would play an even bigger role than they've been playing as we see these gaps. What I wonder is whether some of the pieces that Glenda is talking about, particularly, in other countries that have less capacity than South Africa, whether UNICEF could start to fill these gaps of prenatal testing, making sure that ARVs are available during pregnancy as part of its services that it's providing to children and pregnant women. So I think that is, in principle, something that could happen. They have the infrastructure, and the infrastructure is in many ways the most difficult to do. They need presumably more resources than they have now to do it, and certainly not a cut in their resources. So, I mean, again, maybe this is something that we can collectively push for. Maybe there are other donors that would be willing to increase their funding for UNICEF if they're taking on some of this role.
Thanks, Stephanie. Glenda?
Yeah, I think UNICEF as a global procurement agency and as a very important global player will be critical in some of these areas. They need to work very carefully with the local governments and local departments of health to ensure that there is cohesion and integration. And in some instances, I'm reviewing a PhD from Zambia, where they looked at the PMTCT program, and the multiple donors with giving different advice and different support can derail a program. So if there is going to be a role of global funders and UNICEF, this has to be done closely with the districts and the national departments of health to prevent a role, to clarify roles and ensure that the recipient, which is the mom and her baby, are beneficiaries of this program, and that there's no confusion about who's delivering what. So I think that whether it's the Global Fund or whether it's UNICEF, they need to work very carefully with local entities. I agree that countries need to strengthen their health systems, but we are seeing a disintegration of health systems in Southern Africa, and this reliance on funding has derailed the systems. But we also need our local governments to support and invest in public health systems so that we can become more autonomous when it comes to delivering care and taking care of citizens of the country. So I think it's going to be important to see how global players act, and whether we can harness that additional funding that countries like Malawi, Zambia, Uganda are facing, and the kind of disintegration that they're seeing, maybe much more acutely than in South Africa.
Thank you. So, I mean, you're quite right that governments should really put some more money on the table in terms of advancing healthcare in their own countries. Be very good to come up with a set of metrics that can do that. And have a good balance between how much they ought to spend and what their health burdens are in this country. And I think we have been urging governments to do that, certainly in the pandemic response area, for quite a while now. And this is a moment to, in fact, double down on that call, double down on the advocacy around that, and really to encourage governments to innovate in this area. However, right now we've got a crisis, and therefore, the governments are doing the best they can. I mean, perhaps they can do more, and they should do more. We should press them, but nobody does not recognize what it is that needs to be done. This is life-threatening, and therefore it's a moral thing. It's not just a technical thing, and therefore we have to respond appropriately. And then part of that has to do with the morality of what it is we do, because it's the right thing that ought to happen. So I wanted to just go back to a very practical issue around procurement and about financing, because companies, being companies, obviously can't produce therapies and vaccines ahead of time unless there's a guarantee that it'll be paid for, which is of course right. So, and I just wanted to comment that clearly will require attention. We don't represent companies here, but there's a need for innovation in delivery and logistics. And some of those innovations have come about during COVID-19. We need to know, we have metrics for this, to speedy delivery of vaccines and speedy delivery of therapies, and using proper transportation systems and AI to help along the way. I mean, so that can be done. Smarter ways of financing, and smarter ways of actually delivering the healthcare that's required. But right now there's a crisis, and clearly we need to prioritize. We need to focus on children and mother to child transmission, and build up a program under duress. I mean, we had hoped that the US government, at least if it's going to phase out money, phase it out over time. So you manage the process. Right now, it's a crisis response, so it's very, very difficult. But that is what we have. Could I ask the following series of questions, starting with Stephanie, about what can be done in the United States beyond the contribution, of course, the fundamental contribution came from the federal government. But if that's not forthcoming, which it doesn't look like it is, are there other ways in which the US can respond? Because just to say that South Africa and South Africans should hear this, has many, many, many long-standing friends in the United States, from its professional associations in the healthcare area to its foundations, to its citizens, to its churches, long history of relations. And so what has happened right now is not the act of those friends. It's the act of a constituency that is isolationist and is not moved by the same set of norms and values that we are moved by. And so the question is, it's not the same as the US federal government, but what can the academic, and I ask that question to ourselves, but what can the academic, what can the corporate, what can the philanthropic, what can the professional associations, what can the non-governmental organizations in the United States do to help Southern Africa weather this storm? It's not only South Africa, as you heard, all the countries surrounding South Africa, from Eswatini to Lesotho to Botswana to Namibia to Zambia to Zimbabwe. I mean, it's Southern Africa as a whole and stretching up East Africa and elsewhere. So, but to ask that very broad question, what can we do and what is to be done?
Yeah. Yeah. So, I think there is so much chaos right now and confusion in the United States about what is happening on a number of fronts, but very much on the foreign aid front and global health broadly, that I do think one core piece that is very helpful, and there are different groups that have started doing this, but is just getting to the very specific, numbers of lives that are at stake, but also how much funding is necessary to, Glenda, when you're giving the example of, we'll have children who are born and are not going to live to their first birthday. I think there is a very specific question for different countries, but also collectively, of how much money would be needed to make it through the next year and save those lives and give everyone time to catch their breath and figure out what the plan is to put in place. So I think getting to some of those really concrete, specific messages would both be helpful for advocacy purposes toward the government in the United States, but also for philanthropies that are based in the United States, for private giving, for charitable giving. I mean, this is a program that, as you know, and as you're alluding to, Wilma, it was created by George W. Bush. It has had strong support from the Christian community, from churches throughout the country, from across both sides of the political spectrum in the United States. There are a lot of people who are watching and wanting to figure out how they can help. And so I think, what are those numbers? And then if there are people, whether it's philanthropies, every philanthropy is not the Gates Foundation in terms of their budget, but if there are people or philanthropies that want to help, how do they do it? And so I think there's just kind of a practical, like, what is the mechanism to help right now if you're not the State Department, that we need to get to and make it really easy for people. People are horrified watching, they want to help, they don't know what to do. So I think if we collectively can get some answers to that, we can channel a lot of this energy, at least to try to give everyone a little more time to catch their breath and figure out what to put in place.
Thanks, Stephanie. Do you think there's a special role? I mean, there's a philanthropic side and there's a volunteer side, but do you think there's a special role for health professional associations in the United States, from associations of pediatricians to others?
Yeah. Absolutely. And also, I know some of the questions or comments in the chat were about, watching the emergence of more drug-resistant strains of HIV. I think there are some of these arguments that can be woven together, and hearing pediatricians who are all over the United States reach out to their local representatives about what is likely to happen. People, I think to this community, it's obvious how quickly the impacts will be on human lives. Most people don't understand that or know that. And so I think putting that information together, getting it into the hands of professional associations all over the country, not just in Washington, I believe will be impactful.
Thanks, Stephanie. Glenda?
Yeah, so we have been working. So I see Kennedy's asked about blended financing and things like that. So we have been looking at innovative finance models. So when this happened immediately, in the first couple of weeks, we were trying to see how could we fill this 90-day gap that were putting 20 to 30,000 nurses and healthcare workers at risk. And there are certain social impact bonds and kind of cooperative agreements with private banks. There was interest in finding innovative financing mechanism, but all these things take time. And so we were faced with setting up these systems would take a year. And we literally had 10 days. And so what we do need is this rapid response to rapid financing response, which doesn't exist. You have to do the contracting, you have to, do the engagement, you have to get Treasury has to approve the funding. So we have to be a little bit more efficient in the way we respond in a crisis. There was like we had a solidarity fund during COVID in South Africa. There was talk about reviving a solidarity fund with public-private partnerships in South Africa, bringing in the business associations. And so, that's an important element to continue to pursue in South Africa. So there could be this kind of financing mechanisms that we saw during COVID and some of these innovative finances that are experimental at this moment in South Africa, but important to address. So I think that's an important. Other things, what you talked about, procurement and tenders, and we do have when we bring in foreign goods in South Africa, there is this ability to offset, and we hardly ever call in the offsetting, and there's a lot of money that is sitting that could be claimed as offsets to finance a crisis like this, and that may be one way to work with the Department of Trade and Industry to basically use offsets as a way of funding or use offsets as a way of doing the supply chain management. So I think innovative financing is an important part of the lesson we've learned around the rapid reduction or the rapid loss of funding for essential components of programs.
So thanks, Glenda. You mentioned the Solidarity Fund. Just to note that that was a really successful public-private partnership. People often speak about that in the abstract, but it actually really worked very well, just to acknowledge that. So, South Africa's chair of the G20 this year. It's also a member of the BRICS consortium, which is more than it's Brazil, as you know, Brazil, Russia, India, China, and South Africa, but more countries have joined that. I'm sure South Africa is going to leverage its G20 membership here in order to get some support from the G20, except the US. And also can certainly leverage its BRICS relationships. Do you have any comments on that, Glenda? Just starting with you.
Yes, I think that obviously it's our relationships with BRICS and the BRICS Bank and our relationships with other partners are important. And I guess we would have to see how that plays out in terms of geopolitics and our situation in South Africa with our relationships are incredibly tense with the US with an executive order and sanctions and other impact. And so I guess we have to tread the geopolitics very carefully. US is a very important trade partner to South Africa, and we have to be very nimble in the way we manage our advocacy around funding to ensure that we don't find ourselves in a position that makes us even worse off than when we started. So I do think the BRICS are important partners. I think India is also an important player, particularly for trade into South Africa. So I think we need to look at some of these partners to see whether they can support them. But we do know a lot of the BRICS countries are also facing financial crises, and so I guess it's going to be a balancing of geopolitics and internal resources and how we manage. And I guess this is what diplomacy is all about. And hopefully with the G20 being in South Africa, although a lot of resolutions are unlikely to be made, just some kind of collaboration to look forward to. We also have to strengthen our relationships with the European Union and also look at Southeast Asia as ways of building strong ties. So I guess, Wilmot, it's about how to play the politics of the world that doesn't affect your trade, but also helps to finance the work that you need to be done. And maybe there are innovative ways. Maybe the first thing we can do in South Africa is make sure we spend our money properly and I'll become more accountable with the public purse and with taxpayers' money.
Thank you, Glenda. There's circumstance. I take the point about the geopolitical balance that we need to have in making sure that we serve national interests. In this case, South Africa's national interest is to preserve life. And there's a special category. HIV/AIDS is a global thing. It's not confined to one country. It is a global thing that requires global participation. And countries don't have the same level of resources. So just to say that. And secondly, this is an existential crisis. And we sometimes must suspend our approach to foreign affairs when you're dealing with an existential crisis, when lives are at stake. So let me just say that.
Well, Mike, could I just come in on this? I just wanted to add that the African Union is incredibly powerful and has the ability to put a lot of pressure on all of those actors. So I know that the way that the U.S. government is interacting with the AU obviously is different and will be different from how it was in the Biden-Harris administration. But in terms of even economic considerations, where the AU is and what the AU is asking for matters a great deal to the United States, to Europe, to the other BRICS countries. And so I do think, again, coming back to just having a really clear, unified ask and call to action from the AU would be, it would at least be uncomfortable and put pressure on some of these countries that we're talking about and is worth really pursuing.
So I entirely concur with that. The public health community in the United States works very closely with the Africa Center for Disease Control, and the Africa Center for Disease Control is the technical support agency for Africa's 55 member states, and it has a program of support. So that's quite right, and it matters because it covers the entire continent. In the end, it's the individual countries who act, but it acts better if it has the backing of the Africa CDC, which it does have. So you're quite right. So thank you very much for that point, Stephanie. We've got a question from Katie Bayala from Brown's Epi Department, and it reads as follows. I would like to think we can get the US public to care about human lives in other countries, particularly in the global south. However, I'm cynical about that. How can we respond in a way that speaks to the people who may not? The impact on the global economy, question mark, the impact on US lives, question mark, the impact on global security. Any thoughts about that? Stephanie?
Well, I'm not sure that the target audience in this moment is Americans who don't care about human lives in the rest of the world, to be very honest. And I don't think that that's the majority. I mean, perhaps there are people, it seems that there are, but I don't think it's the majority of Americans. And I don't know that our energy and the enormous expertise and just the emergency of this moment is worth really focusing on convincing that group of people. I think convincing, I think educating people who do care, who, you know, have been bought in and who want the United States to play a positive role in the world, but maybe are not closely tracking what's happening, is a better use of time and energy right now. And I think that is the majority of people. So that's where just, you know, educating people and giving them really tangible examples of the impacts of these decisions on human lives, I think is important and compelling. That said, yes, I think some of these, you know, there's also a role for some of these, like what is the economic impact in the United States or to US companies of some of these decisions? And what is the impact on US universities? Mostly because that gets them to call members of Congress and put very immediate political pressure on. But I think, you know, I mean, someone was reflecting recently, and while things have changed a lot in the last 20 years, on the fact that when George W. Bush announced PEPFAR, he wasn't making an argument about US interests or, you know, how it will benefit the United States. He was making an argument that the United States should show up in the world when there's a time of crisis and we have a responsibility to help people. So I do think fundamentally that is the identity that Americans have, and that is the one that we can most effectively speak to.
Thanks, Stephanie. So just to say that the proportion of Americans who voted in favor of Donald Trump in proportion to who was eligible to vote puts that voting base below 50%. And so if we were to take that as an indication of who supports this and who doesn't, not that all people who voted for Donald Trump would have supported this in any event. So just to amplify that message, when this happens, this is not America. This is a representatives in terms of public representatives coming from that section of the population. The second point is that with the history of PEPFAR, but other interventions, there's been, certainly with PEPFAR, it's been bipartisan until this moment in time. So it was initiated by somebody representing the Republican Party. So there's an important point to just emphasize. Glenda, could you just reflect, we don't have much time, but spend just a couple of minutes on the following, that if the United States was to rebuild this program, this is, you know, administrations are here for 4 years, maybe 8 years maximum. And then, you know, a next administration comes in. And if there was a wish to rebuild trust in the United States, because many people see this as an act of betrayal, not simply as a neglect. So what would your advice be? How does one go about rebuilding trust when that trust has been betrayed?
I think it's, you know, that's a difficult answer to give you, Wilmot, because there will be skepticism, there will be hesitancy, there will be, you know, the systems may be so fragmented. So like Lesotho, as you mentioned, there may not be much of a health system to even start with. So, you know, there'll be so much reversal of gains made that, you know, we would have lost so much time. And I shudder to think of what's going to happen to these countries in Southern Africa in the next 4 years. And unless there's some global thought about what's happening, and maybe we will even miss it. You know, I read today in the New York Times that the demographic health surveys have been stopped. So these are the demographic health surveys are done every 5 years. And USAID was a large funder of them, and this is the way we monitored life expectancy, deaths, life expectancy in children. So if we stop counting, we won't even know. If we stop counting the dead bodies, we won't even know the harm we've done, and so we may not even know how bad the impact has been because we've stopped the monitoring and evaluation, and we've stopped looking at the indicators. So I don't know how you know, you are right. This is a global catastrophe, and it's counted in lives, and you know, we have you know, I can't even think of 4 years from now when already we know in the next you know, there'll be already people, PEPFAR trackers saying that there have already been 15,000 premature deaths since the pause. And so if you can just multiply that out by 4 years, it's catastrophic.
Thank you. So we've got 1 minute left. Stephanie, 30 seconds. Any last word?
Well, it's helpful, Glenda, to hear your reflections. I think unfortunately it will be very difficult for the United States to regain trust and respect in the world for a very long time. So, but I hope that we will have the opportunity to try to do that. I do think, again, starting to think about what the systems are that we put in place that make, these interventions in the rest of the world less vulnerable to what happens in Washington, D.C. is unfortunately one of the very stark lessons of this moment. So hopefully we can all work on that together.
So thank you very
Well,
much,
yeah.
colleagues.
Well, I just wanted to make one quick note. I want to be grateful for the generosity of the American people to date. And so I don't think we acknowledge the generosity of the Americans and what they have done. And so I just want to acknowledge that and great thanks and for your generosity to date.
Thank you, Glenda, for that. That's a very important message to convey. I just wanted to end by saying that I was privileged to be asked by Nelson Mandela to organize a science lecture on the origins of HIV. And I invited the Nobel laureate David Baltimore to give that lecture. It was given at Wits University in 2007. And I took David Baltimore to see Nelson Mandela. We spent 15 minutes with him. David Baltimore gave a summary of what had to be done in 4 minutes, as only he could. And as we left, Mandela turned to us and said, if governments don't do the right thing, take the fight to them. And I leave you with that message that we really need to take the fights to government on this. This is not something to take lying down. I'd like to thank everybody who joined the panel, Stephanie and Glenda in particular. This is not the last time we're obviously going to speak about this question. And with that, many thanks again, and please go well. Be safe.